I request Dr. Upendra Kaul to deliver his lecture on drug-eluting balloons.
Well, after the number of talks on stent-based technology, let's get back to balloon, and I'll speak on the role of drug-eluting balloon today. We all know the potential advantages of drug-eluting balloon. The local drug delivery is over a short period of time, not for weeks and months. Because of the absence of polymer, it avoids chronic inflammation, leads to better re-endothelialization, which could lead to reduced need for dual antiplatelet therapy. There is no deformity of the original vessel, especially in bifurcation stenting, no need of double, triple layer of metals, especially in in-stent restenosis. It's much easier to cross than any low-profile stent, and there can be no fractures later. After a number of years of work, investigators like Schuller from Germany showed that paclitaxel eluting balloon is a sturdy technology, and they came out with the balloon with paclitaxel with iopamide as one of the excipients, which could predictably and reliably lead to drug release. And the results in the experimental animals were, in terms of neointimal hyperplasia reduction, were equivalent or better than a stent. And then came the clinical studies of in-stent restenosis of a bare metal stent using the PacoCat technology, and it was very clear that as compared to a plain balloon, the paclitaxel eluting PacoCat had a much lower late loss, as you can see, 0.74 versus 0.03, and this was seen at the end of 6 months, and these results transformed into a better clinical outcome, not only at 1 year, but these continued up to 4 years, indicating that this was a robust technology. And then came Dr. Noorburden's study comparing paclitaxel eluting balloon with DAXA stent in bare metal stent in-stent restenosis, where again the results seemed to be, if not equivalent, better in terms of late loss, because it was not a very highly powered study for clinical endpoints, but then the clinical endpoints were also better, less restenosis, less late loss, resulting in better clinical outcomes at the end up to 1 year. So the guidelines, at least in the Europe, changed, and drug-eluting balloon for the treatment of in-stent restenosis of bare metal was given a 2A status based upon these 3 studies. And as you know, drug-eluting balloon is not a class effect, so it's all related to this particular balloon. That is the sequent, please. What about drug-eluting balloon for in-stent restenosis of drug-eluting stents? Well, there were some small studies showing that it benefits, but we had to wait till the ISR Desire 3, which clearly showed, when compared with paclitaxel eluting stent Taxus, the sequent balloon and balloon angioplasty alone, in a 400 patient series divided into 1:1:1, with the primary endpoint of angiographic late loss. And the primary endpoint clearly showed that paclitaxel eluting balloon was equivalent to paclitaxel eluting stent, with the criteria of non-inferiority clearly met. And when you compared with the plain balloon, clearly it was superior than the plain balloon in treating the late in-stent restenosis of a limus. And if you come to the binary restenosis, the paclitaxel balloon was comparable to the Taxus stent, which was much better than the plain balloon, and the target lesion revascularization rates were also clearly in favor of paclitaxel eluting balloon or paclitaxel eluting stent, thus showing that the paclitaxel eluting balloon and the Taxus stent were equivalent in terms of their clinical and angiographic results, with the balloon having the advantage that there was only one layer, there was no new layer of metal being put in. Well, these are some of the other indications which are conceptual, small data, small coronary arteries, situations where you actually want to avoid a stent. Chronic anticoagulation therapy, bifurcations, side branch when you don't want to put in a stent, and long lesions when you want to avoid a full metal jacket. And this is the PepCAD-Vent study showing that if you can achieve a very good result with the balloon, you can have a very good result. But if the result is not good and you put in a bare stent in that region, but there is no geographic miss. The results are still very good, but if there's a geographical miss, that means you put the stent outside the region where you had balloon with the paclitaxel eluting balloon, results may not be so good. Last year, the Bellow study again showed that in small vessels, the late loss was clearly in favor of a drug-eluting balloon as compared to a drug-eluting stent, and the clinical outcomes were also in favor of a drug-eluting balloon. Well, this is our study in which we showed that paclitaxel eluting balloon and the combination of a bare metal stent in two sequences, that is, if you release the drug first and then put in the stent, or put in the stent first and then use the drug-eluting balloon, it showed that they were equivalent, but the sequence does not matter, and the late loss achieved by a bare metal stent, which was Coroflex Blue, the late loss was identical in both, and it was the late loss which you get with Taxus, around 0.4. And the clinical outcomes were also equivalent, sequence did not matter. So the combination is feasible, the sequence does not matter, and we believe that bare metal stent can be used as a bailout for drug-eluting balloon-induced suboptimal result, and the late loss is identical to that of a Taxus. Well, then some concepts like EPC capture stent, which is a high late loss. When you combine it with drug-eluting balloon, you could see that the late loss was clearly lower when you use the combination, and also the long-term results, although the sample size is small, were clearly much lower need for another procedure if you combine the two. What about peripheral vascular disease? Once again, angioplasty of legs, the late loss clearly lower with the PACO-cath as compared to the balloon. And in other superficial femoral artery outcomes, a number of paclitaxel eluting balloons have clearly shown that the results are better than the balloon in terms of long-term results and angiographic follow-up results. Similarly, peripheral vascular disease infrapopliteal, the results are identical, and then some miscellaneous utilities like stenosis of a AV shunt, where there's a narrowing, dilating that shunt with a paclitaxel eluting balloon produces much better results than a plain balloon. And also, the stents put in by the neurovascular radiologists, small stents, when they restenose, the drug-eluting balloon clearly has better results. So there are a number of drug-eluting balloons which are in the pipeline, and from various companies, and some of the newer balloons like from Biotronics, Elutrex, Pantera, they seem to be quite good and maybe equivalent or better than Sequent, please. But what is more promising is some of our work on the world's first sirolimus-based drug-coated balloon, because all of them have been paclitaxel-coated because of the drug is lipophilic. This one has a nanotechnology, microspheres of sirolimus coated with the lipophilic material and coated on a balloon with a special technology. It leads to good acute transfer, low transit loss, single inflation delivery, and retention of drug for duration of treatment. And a number of preclinical studies, this one done by Renu Virmani, very clearly shows that these DTTF-labeled sirolimus nanoparticles get lodged into the intima and within 7 days go up to the adventitia, not because of the drug transferring through some other route, but they go through the vasa vasorum and lodge there. And then the clinical studies in animals showing that 1:1 ratio is the best, and OCT results clearly favoring the drug-eluting balloon with the sirolimus as compared to a stent. And now we have a number of first-in-man studies in this country, and I am the PI of one of them, in which we are using all-comers with a combination of sirolimus-coated drug-eluting balloon. As you know, sirolimus is a better drug than paclitaxel. If we can make it reach effectively, it may be better in ISR, in all-comers, and the studies are already started recruiting patients. So friends, I would like to conclude that drug-eluting balloon has evolved into an acceptable technology. Its utility in treating in-stent restenosis of bare metal stent and drug-eluting stent has been well documented. There is data to suggest that it is a good adjunct in situations where you want to avoid a stent like in small vessels and bifurcation, below knee, peripheral vascular disease, and also areas of suboptimal results after a drug-eluting balloon can be treated with BMS with the results identical to a drug-eluting stent. A number of new products are in the pipeline, including the very exciting sirolimus-coated drug-eluting balloon using nanotechnology. Thank you very much.